My name is Andrew Spanyi. I live in the Niagara region, and I was a caregiver for my wife over 2 decades as she fought cancer. My wife, Katalin, was first diagnosed with breast cancer in 2003. She was only 42 at the time. We were both totally stunned. We knew nothing about cancer. So Katalin decided to follow the recommended treatment of surgery, chemotherapy, and radiation in 2003 and 2004. I cut back on my out-of-town consulting work and drove her to her treatments and provided support. The chemotherapy and radiation treatments that she took over an 8 or 9 month period were invasive, highly toxic, difficult to tolerate, and they had several side effects. But they did do their job. Katalin was cancer-free from 2004 through to 2015. Sadly, the cancer returned in 2016 and had spread to the scalp and the bones. This time around, we were both calmer and planful. We had returned to the Niagara region in 2014 after Katalin had taken early retirement from her position as a marketing professor in Connecticut. So in addition to her local oncologist in Niagara, we were fortunate to still have access to her former oncologist at UConn. The first line of treatment in 2016 was a hormonal medication, letrozole, recommended by both the local oncologist here in Niagara and the UConn oncologist. It provided Katalin with progression-free survival for almost 2 years. When a CT scan revealed minor disease progression, the next recommended treatment was a drug combination involving palbociclib and Faslodex. This worked too for almost 2 years, from 2018 to 2020. And it was during this period that we sought out additional resources. We obtained second opinions from highly regarded oncologists at both Sunnybrook in Toronto and Roswell Park in Buffalo. My friend Brad Power, founder of Cancer Patient Lab, as well as 2 oncologists, also recommended that Katalin undertake next generation sequencing for her tumor. And she did that in 2020. These results revealed that targeting the PI3K pathway may be an effective way of treating Katalin's cancer. But my wife's local oncologist in Niagara was not aware of a suitable clinical trial that targeted that specific mutation. We discovered the existence of a suitable trial through a second opinion consult at Sunnybrook Hospital in Toronto. As I reflect on our experience during those 4 years from 2016 to 2020, I think we did a few things well. Our constant advocacy, our habit of asking a lot of probing questions, seeking out highly respected oncologists for second opinions, and arranging for next generation sequencing all contributed to finding the right next treatment. And I would recommend that any caregiver consider doing likewise. Katalin was accepted into a clinical trial that targeted the PI3K pathway in June of 2020. And she participated in that trial from June 2020 through to October 2022, at which time she was released from the trial due to minor disease progression. She benefited from the clinical trial for over 2 years, and she was grateful for the opportunity to participate in that trial. But as I looked at her experience from a business process perspective, I was shocked at how poorly the trial was designed and executed. These were not just casual observations by a concerned caregiver. I had spent 3 decades advising Fortune 500 companies on how to design their processes, and I had written 3 books on this subject. I observed the following issues in the clinical trial process. The informed consent form was unduly technical and difficult to navigate. The screening process was unnecessarily burdensome. Appointments lasted up to 8 hours, very difficult for a sick patient. The typical visit during the conduct of the study was equally onerous. There was no option to have some tests done locally for out-of-town patients to ease the burden of lengthy trial visits. There was no consideration whatsoever of the caregiver's experience. Transparency was lacking in the handoff from the study doctor to my wife's local oncologist upon release from the trial. A lot of issues, but let's be clear. Clinical trials are central to bringing new cancer medications to market, but they are very expensive and take a very, very long time. On average, it takes over 10 years and costs well over $1 billion to bring a new oncology medication to market. The probability that a cancer drug will make it from phase 1 to final approval is somewhere around 2.4%. Oncology clinical trial performance is by far the worst performer across all therapeutic areas. Once Cutulin was released from the clinical trial in October of 2022, we sought out the opinion of 2 oncologists, and both recommended a drug combination that treated Cutulin's hormone-positive and HER2-negative cancer by inhibiting mTOR as the next course of treatment. These medications worked until July of 2023, at which time a CT scan revealed that the disease had progressed to Cutulin's lungs. She passed away just a few months later in November. Since then, I have been writing articles advocating for innovation in oncology clinical trials by focusing on factors such as patient experience, decentralized testing, optimizing the use of artificial intelligence and genomics in order to radically reduce the time and expense of bringing new drugs to market. I hope that my articles will make a small contribution and cancer will eventually be cured. But it's not going to happen overnight. In the meantime, it's important for caregivers to advocate for their patient, to ask a lot of probing questions, to seek out highly respected oncologists for second opinions, to invest in next-generation sequencing for the patient, and to take advantage of evolving resources such as Cancer Patient Lab and Cancer Commons. Thank you for your attention.